So do you mind, ladies? Now I'm ready for you. Anyway, it's fun to be here, and thank you for coming all this way. And we're going to have a very, very good day. I first want to thank Elise and Mark Lefkowitz for sponsoring this wonderful event. Where are they? Elise, where are you? Where are you? She's there somewhere. Raise your hand. In any event, they have been great to us and great for everything. And Saks Fifth Avenue for underwriting this. Saks Fifth Avenue, thank you. Here's the commercial. Saks Fifth Avenue was the first store that Estee Lauder sold in the world, okay? And so that I'm able to stand here reasonably well dressed. Thanks to Saks Fifth Avenue. I have to tell a little story. So when this goes back to 1948, and my mother, who some of you may remember, was very clever and had a good sense of things, said to Saks Fifth Avenue, "Do you mind if I send out a few invitations to my customers to invite them to Saks Fifth Avenue?" And they said, "No, not at all." Well, I, as a high school student, got 25 cents an hour for stuffing envelopes and sealing them. She sent out 5,000 invitations. We never looked back. So I owe a great debt to Saks Fifth Avenue, and Mr. Ronald Frash, the president of Saks Fifth Avenue, is in the back there. Thank you, Ron. And Ron, that's how it's done. And also to Sharon Percy Rockefeller, who for joining us and allowing us to be a coach of Sharon. Now, later on, by the way, when you see her turn around, you see her face, she has this beautiful lipstick on. You know, I never stop selling. Forgive me. Let me just give you just a quick word about the foundation, because we'll talk more about it at lunch. There's hardly a week that goes by when there's not an article in the paper about Alzheimer's. People are setting up major new research foundations and the money from the government. But here's the thing. They are putting money into basic research, which is terrific. Basic research is here. Final drug development by the pharmaceutical companies is there. And in the middle, there is no money. Nothing happens. Nothing happens. And so they come up with these wonderful ideas, etc., and there's no money to go into what we call phase 1 testing of a drug, or phase 2, or 2A, or 2B. That's where we step in. So, listen, we are doing an incredible job. We're the only people doing drug discovery. So that I feel passionate about this project, passionate about finding drugs to prevent and cure Alzheimer's, and passionate about the cause of making this a safer and better nation in the future. Because I owe a great deal to the United States. We all do. They educated me. They protected me. They allowed me to serve in the nation's Navy. And I want to see this nation thrive. And we can only thrive if we are a healthy nation. And thanks to the work that's being done here, we will make this happen. So, Andrea Mitchell was supposed to be our MC today. However, she went with John Kerry to China and Korea. You may have seen one or two things going on in Korea. So Andrea is doing a major work there, and I imagine that you'll be seeing her on NBC. But it's a dicey situation. And for those of us who know a little bit about Korea. They're playing a game of brinksmanship, which is unfortunate, but that's the game. So I'm going to ask Nancy Lin, the ADDF's Chief Operating Officer, to step in and be the moderator. So, and she looks cool. Nancy, thank you very, very much, and thank you for joining us.
Thank you, Leonard. That's because it's Jason Wu, of course. It's Jason Wu. Thank you so much. I'll do my best. This is not my normal role to stand in for Andrea Mitchell, and just everyone say a prayer for the work she's doing in Korea. And thank you all for joining us this morning for Dr. Howard Fillit's presentation, Conquering Alzheimer's Disease, a Progress Report. Leonard has a saying, if you have not had experience with bad things, it's easy to ignore them. Anyone who has had experience with Alzheimer's disease knows much too well it is devastating emotionally, physically, spiritually, financially, and it cannot be ignored. Over 5 million Americans today have Alzheimer's disease. 1 in 3 people over the age of 80 will develop the disease. And in 2012, it cost the U.S. economy over $200 billion in direct costs. And yet, as Leonard was saying, there are no drugs today that can prevent or even slow the course of this disease. And so with this daunting information in mind, it is my great pleasure to be here with you today to introduce a very innovative, progressive venture philanthropy foundation in the Alzheimer's research field, the Alzheimer's Drug Discovery Foundation. A unique aspect of the ADDF is the precise single-mindedness of our mission. We fund scientific drug research to discover the drugs that will one day prevent, treat, and cure Alzheimer's disease and related dementias. And that's all we do. We focus solely on finding and funding the most excellent cutting-edge research anywhere in the world, whether it's at a great academic institution here in Washington, D.C., or at a startup biotechnology company in Sweden or Australia or Canada or Israel. We've funded in 18 countries so far with $60 million. And because every penny of our overhead and administrative costs are paid for by the Lauder family, 100% of every donation that we receive goes directly to drug research and related programs, including every penny that you have given us today. So, we thank you for supporting us in this event, and we invite you to join us and to join Mr. Lauder in fighting what is certainly one of the century's greatest scientific battles. So this morning, Dr. Howard Fillit will share an insider's view of what's happening in the field of drug development for this uniformly fatal illness. We will leave time for Q&A with Dr. Fillit after his presentation, and at a little before 12, we'll ask everyone to regroup in the main tent for the luncheon and fashion show. And so now, Dr. Fillit has been the driving force behind the ADDF since its founding in 1998. He is an internationally recognized leader in geriatric medicine and Alzheimer's disease with over 30 years career experience in academia and industry. He's had a distinguished academic medicine career at the Rockefeller University in New York, and he currently holds the title of Clinical Professor of Geriatrics, Palliative Medicine, and Neuroscience at the Mount Sinai Medical Center. Will you please join me in welcoming Dr. Howard Fillit?
Okay, I have to say it's quite intimidating to be here this morning, but it's a great privilege to be with you this morning and to talk to you about Alzheimer's disease, which has not only been my life's passion, but also, like you, I've been personally affected. Since we started working in the field more than 35 years ago, there's been great progress. And it's really my privilege today to tell you about the progress that's been made. Let me begin by saying that aging is the leading risk factor for Alzheimer's disease. So the risk of Alzheimer's disease goes up linearly with age. And as Nancy mentioned, by the age of 85, about 1 in 2 people will have Alzheimer's disease. We don't understand all the science behind that. Why is aging the leading risk factor? But we do understand a lot of the clinical aspects of it. And one thing that's interesting is that the brain actually peaks around age 20 in terms of cognitive function. You can see here at around age 20, things like memory, word recall, the ability to remember things in the immediate and delayed person past right away, and reasoning, and also something called processing speed, the speed at which we think, just like a computer has a processing speed, peaks at age 20. And by the time we're about 60 or 70, we've lost about 50% of processing speed. And just like your computer, if you lose processing speed, it makes multitasking more difficult. And so that's one of the reasons why we find as we age that multitasking is more difficult. We have trouble remembering names. We have trouble, we have words on the tip of our tongue, like I'm having a little trouble this morning. And, but that's because processing speed is slowed, and we're trying to pull those words from our storage areas, and it's just like trying to pull data off your hard drive. And so that's well known. Not everyone experiences this, but the vast majority of people do. Now that loss of cognitive function with age, which we consider normal, is associated with a loss of brain volume. So after the age of 50, we lose about 0.4% of our brain volume. The brain is shrinking. And that's one of the clues that we have to what's going on as we age. Now, the question I always get in my practice is, what's the difference between aging and dementia? Or when is it dementia? And so here you have a fairly typical situation. This is my wife of 42 years, Lisa. Now, the thing is, when somebody's demented, they have neurological symptoms that are cognitive, and we have big words for those. Of course, amnesia describes memory loss, and there's lots of different kinds of memory loss. And maybe this man can't remember his wife's name, but more likely he has something called aphasia, which is a language disorder. So the language centers of the brain are falling apart with Alzheimer's disease. They're affected fairly early, and it's what we call receptive and expressive aphasia. In other words, receptive means I start to lose the ability to understand what you're saying, and expressive aphasia means that I can't express myself. I have a language problem, and that goes all the way through not only verbal language, but also emotional language. People can't read faces. And that leads me to another symptom, which is called agnosia. And here's this man, he says, I remember the face, but I've forgotten your name. So his vision is intact. He knows this is a face, but he doesn't recognize it as himself. Now this is a very serious symptom. There's a part of your brain that takes in visual information, and it codes it and categorizes it so that normally he would be able to, what I'm seeing here is a face, and it's my face, but he has agnosia. Now what does that mean in terms of the disease? It means that when he eventually gets more serious agnosia, he will see a plate of food and not recognize it as food. Or he might see a stapler and try to eat it because he's hungry, but he doesn't recognize what he's seeing. And so that is one of the reasons why people, as they get into the later stages of dementia, begin to require home care. And in fact, one of the most serious symptoms is apraxia, which means that to do cognitive tasks like tying your shoes, dressing yourself, going to the bathroom, using a telephone, it's not just a motor task. There's a very large cognitive component to sequencing that. So if you want to eat, you have to recognize the food, you have to pick up your fork, you have to put it, put it into the plate, get the food, put it into your mouth, and then swallow properly. Now, the failure to sequence those events is a cognitive task, and when you lose that, you have apraxia, which is why this woman who is not paralyzed has to be fed, because she's lost her mind, she's forgotten how to eat. Now, eventually, this woman is going to forget how to swallow, because there's sequencing and swallowing, And when she forgets how to swallow, she's going to start getting food in her lungs. From that, she's going to get recurrent pneumonias, and she's going to die from the pneumonia. So when people ask me, why is Alzheimer's disease a fatal disease? It's because most commonly, people lose the ability to eat, to swallow, to feed themselves. If they're not properly fed with home care, they become malnourished. They get that pneumonia, and the most common cause of death is pneumonia. So this is not just a disease of forgetting where you put your keys. There's a lot of neurological, cognitive symptoms that we know about. But it does start, in terms of clues, the next question is what I've described to you is the difference between normal aging and dementia, which describes those patients. They have agnosia, they have aphasia, they have apraxia, they have amnesia. That's dementia. The next question your doctor should ask when he's evaluating a patient is, what is the cause of the dementia? And Alzheimer's disease is by far the most common cause of dementia in older people. It starts right here in the brain, in this area called the hippocampus, which is literally the memory module and the learning module of your brain. That's where your brain actually learns and remembers things. And when you look under the microscope in this area, what you see are the plaques and tangles that Alzheimer saw in 1906 in a 52-year-old woman. The plaques were the first clue. These are called senile plaques because they're not normally seen in a normal brain. And they contain the amyloid that was one of the first clues that we've been working on to develop new drugs, because the thinking is that these plaques are toxic and they kill brain cells. And if we get rid of these plaques and prevent them from happening, we would be able to treat Alzheimer's disease. The other thing that Alzheimer described are these tangles. They're dying neurons. And here's a normal neuron, nice, lots of connections, and everything looks healthy. And here's a dying neuron. And what Alzheimer saw under the microscope were dying neurons. Now, when you lose your neurons, that's when you become demented. So we want to prevent the neurons from dying, and we think that the plaques might be one cause. Now, one of the great advances that's happened in the last couple of years is being able to see the plaques in human beings. In the past, people would say to me, well, how do you make a diagnosis of Alzheimer's disease? Do you have to do a brain biopsy? Or I thought the only way you could make the diagnosis was at autopsy. And that's not true anymore. As of last year, a new test came to market called the Amyvid test, which is PET amyloid imaging. And what it is there's a molecule that gets radiolabeled. You inject it into an artery. It goes up into the brain. It binds the amyloid if it's there, and it lights up on a regular PET scan in your radiologist's office. So now I can see if you, any one of you, have plaques. And I say that literally because what we learned from this test through research is that the plaques start 20 years before people get demented. Just like teenagers have high cholesterol, but they don't develop a heart attack till they're 70. We know that this disease starts 20 years. So if the average age of onset is about 75, 72, we know that people 52 years old are starting to get plaques. And that's enabled prevention studies. We can now see people at risk and start thinking about prevention. But the other thing is we can make an early diagnosis. And the real value of the test is that we see a lot of people today who come into the office, they're 75 years old, and they have memory complaints. And I can do neuropsychological testing, and I can tell them whether or not their memory complaints are normal for their age or too far gone, like a standard deviation or two beyond what should be normal for their age. But that doesn't tell me what's going to happen to them. Because those people I would label before they got agnosia, aphasia, apraxia, all that stuff, they have something we call now mild cognitive impairment, which means these are your average 72-year-old, 65-year-old, even 80-year-old who comes in and they have memory problems. And I can document these memory problems. But the thing is that in 3 years, 50% of those people who have a positive amyloid scan will develop dementia from Alzheimer's disease. But 50% of those people who have a negative scan will potentially get better. And I've seen this in my practice already. We can actually take people who have mild cognitive impairment, and if we get them off sleeping pills and we get them less stress and we get them to exercise and we get them to a better diet and all these other things that we can do, and take them off medicines that might be impairing their memory, we can make those people better. So this is a fabulous prognostic tool. It was approved by the FDA last year. It was approved by the European agencies last year. And I'm very proud to tell you that our foundation started this program at the University of Pennsylvania in 1999. We funded it for 4 years. The company was spun out by Penn in 2005. It was sold to Eli Lilly in 2010 for $800 million. And it came to market just last year. So we're very proud. That's progress. Thank you. Now, there's lots of new stuff on the horizon. There are imaging agents for the tangles. We'll be able to see the dying neurons. We'll be able to quantitate them. And there are other imaging agents that we're supporting and others are supporting that will help us to diagnose and understand this disease much better. And particularly in terms of understanding the disease. I think my slide thing here died. Okay. In terms of understanding the disease, this test has made a critical difference in human clinical trials, because if the plaques are the signature of Alzheimer's disease, and amyloid is the main target of current available drugs that are being tested by big pharma in clinical trials, in phase 3 clinical trials, then we want to be able to use this test not only to identify the people that really have Alzheimer's disease that go into clinical trials, because we know from this test that 30% of people that enter clinical trials for Alzheimer's disease, now we know they don't really have Alzheimer's disease, which really makes a mess of the whole thing. But in addition, we can use the test to see if the drugs work. So here was a phase 2 study. The placebo patient, this is their frontal lobe where they do abstract thinking and planning and judgment. And here's the temporal lobe where that hippocampus is, memory and learning. And you can see that over 18 months with the test, that the people who got placebo accumulated, the red is bad, they accumulated more plaque. They got worse. And the people who got the vaccine actually got better. But the problem is that when we went to a $400 million, 3,000 patient phase 3 study, the drugs failed, okay? And so we've had many, I would say at this point, many clinical trials trying to attack the amyloid, and they've all failed to date. Now, this doesn't mean that the amyloid story is over, but it means that we have to have more innovation in our field. We have to have many other ways to find new drugs, and that's exactly what ADDF has been doing. We haven't funded an amyloid project in over 5 years because 5 years ago we strategically said we have to move on. So let me tell you about some new drugs that are in development. And I'm going to talk about, I'm going to talk about some research to tell you how we develop new drugs by looking under the microscope, which I've already told you the plaques and tangles became our first clue. And then understanding from basic biology research how we can develop new drugs, new targets, and finally, how we can translate what we know about risk factors into new drugs. Now, we know that I told you that the disease starts in that area of the hippocampus where there's memory and learning, but it spreads to most of the brain. Understanding how the disease spreads is a potential therapeutic target, because if we can stop the spreading, we can stop the progression of the disease. And I'm not going to go into details on any of these. I'm just going to try to tell you what's new. There's a tau vaccine. We talked about an amyloid vaccine. There's basically a tangle vaccine that attacks a molecule called tau that is thought to be responsible for the spreading. And in addition, there are small molecules, in other words, pills, that one can take that may also stop the spreading. So stopping the spreading is an active target now for treating Alzheimer's disease. And it's actually in clinical trials right now. That's tau vaccine. You're going to hear about it. I told you that the brain cells die. They die progressively. So with aging, brain cells, actually, the trees get more complicated as we learn things. But with neurodegeneration, the trees kind of fall apart. And these long connections that are responsible for the way we think, these long axons, these tubes that carry the electrical signals that enable us to think, fall apart. And eventually, the brain cell dies. So we would like to have drugs that protect the neurons from dying, a neuroprotective strategy, and we want to have drugs that prevent the connections from disintegrating. And I can tell you that these kinds of drugs are now in development, both in clinical trials by big pharma and some innovative novel drugs that we're supporting and NIH is supporting to do these things, to prevent the connections from falling apart so we can keep thinking, and also to protect the neurons from dying. Now, protecting the neurons from dying is actually really important, because when we're spending 80 years on Earth, we're subject to all of the hits of living on Earth. If you think about it, if you put your car in the garage and you never drive it and you leave it there for 80 years, what's going to happen to it? It's going to age. It's going to fall apart. So we have oxidation, we have recurrent infections that affect the brain, we have low oxygen flows to the brain, we have poor glucose, all of these things. And so we're not going to have one pill. We're going to have many strategies. But eventually, if you think of all those things going into a funnel, coming out at one end, the neurons die, there's ways that we can actually just sort of prevent the neurons regardless of the form of injury. There are ways that we can develop drugs to prevent the injury, to prevent the neurons from dying. And I'm going to tell you a little bit about that. Now, what this is an amazing picture. This is an MRI that's now color-coded. And it's a new technology called DTI. It uses your average MRI machine, but it uses different kinds of software. And with this software, you can actually look at the white matter of the brain. And in the white matter are the connections. So if you think of your brain as an internet, right? You have the memory module, the language module, the recognition module, the visual module. These are all connected by high-speed connections. What enables the high speed is the fact that the connections are insulated. And we can actually see the connections. And now we know that Alzheimer's is not just a gray matter disease, it's a white matter disease. The connections are falling apart. So now we have something where we can actually see the connections. And when we do studies to try to look at drugs that prevent the connections from falling apart, we can use this technology to measure whether the drugs are working. And this is an electron microscope magnified 100,000 times of those connections, and they're insulated by, guess what? Fat. Just like copper wires are insulated, our nerves are insulated by fat, and the fat is what enables us to think because the processing speed of our brain is so fast. The fat is made up of omega-3 fatty acids, and particularly DHA. And there have been studies showing that omega-3 fatty acids and DHA really work in older people as they're losing their memory, and that many people are actually deficient, and we can measure blood levels, and many people are deficient, they don't know it, in omega-3. So that's kind of an advance. A lot of interest now in omega-3 fatty acids. We know it protects the heart, we know it protects the eyes, and now we know it protects the brain, and that a lot of people are deficient. But the other thing is that there are other ways to prevent the connections from disintegrating. And again, I'm not going to go into details. I just want you to come away with the idea that we have a lot of drugs in development now, ADDF and other agencies, to prevent these connections from disintegrating as a strategy. Now, in terms of prevention, there's one robust way that we think you can prevent Alzheimer's disease, and that is exercise. Now, you think, well, exercise is increasing blood flow and so on, and it does. And it prevents heart disease and diabetes and all these other good things. But it also has a direct effect on your brain. And what we've learned from studies that we've supported and others is that when you exercise, you're not just increasing blood flow and oxygen to the brain, but you're releasing what are called neurotrophic factors. Those are your body's natural neuroprotective factors. Remember I talked about neuroprotection a couple of minutes ago? Your body is releasing factors like one called BDNF, one called NGF. These protect your brain cells from that injury. Remember I talked about the funnel? These are the kind of factors that are down at the bottom of the funnel. No matter what happens to your brain, they're going to protect those brain cells from dying. They're going to prevent you from getting dementia. Now, what we did as one example, and we're funding many of these, is that Dr. Frank Longo, who at the time was at UCSF, came to us, and he said, I can use computers to discover new drugs. There's new technology where I know the receptor that this would be the computer visualization of the receptor where those neurotrophic factors are going to go into your brain, or in your brain, and this is the drug. And in computers, what he can do is, he has a software library of 2 million molecules, right? And he can screen those molecules on this neurotrophin receptor and figure out which one fits best. So we funded him to do that more than 10 years ago. And he found one molecule out of 2 million that really works, okay? What we did in 2005 is we said, Frank, this is fabulous, but you can't keep doing this at Stanford, where he was at the time. You need to start a biotech company, because that's going to attract investors, because now it's beyond the ability of granting agencies. You want entrepreneurial spirit in there. You want to bring that drug to market. So we actually literally worked with his lawyers, intellectual property, gave him money through our Biotechnology Founders Program to start a company called Pharmatrophics. And just about 3 months ago, Pharmatrophics, computers got approval by the FDA to go into human beings with their molecule. It's a pill. It'll be the first neuroprotective pill, if it works. It'll be, I think it could really be a revolutionary new type of drug, not only for Alzheimer's disease, but potentially for other neurodegenerative disorders. So far we know that the pill is safe, which is the first part of testing. And then about a year from now, we're going to look in to see whether it works for the first time in people with Alzheimer's disease. So neuroprotection is really important. Genetics. The only thing that's really been found in genetics is ApoE. Okay? Now, ApoE, apolipoprotein E, is a naturally occurring molecule in your blood and in your brain, and it carries cholesterol. And in your brain, what it does is when your brain cells get injured, all the membranes around your brain are made out of cholesterol. So the cholesterol in those membranes start falling apart. And so you want to bring in new cholesterol to repair the brain cells when they get injured, let's say low oxygen, whatever. So the thing is that ApoE does that in the brain, but there's 3 types, 2, 3, and 4. Most of us have 3. About 20% of us have a 4. The 4 is bad because this is what the 3 looks like, and this is what the 4 protein looks like. There's the gene, and then there's the protein that the gene makes. This is the functioning molecule. The 4 is very different than the 3, and it functions differently. It doesn't carry cholesterol effectively, and it doesn't help to remove the amyloid from the brain after injury, which is another function of ApoE, to naturally remove the amyloid from your brain after injury. If you have ApoE, you have up to 15 to 20 times increased risk for Alzheimer's disease. And instead of getting it at 75, you're going to get it at 65. This is powerful. We've known about this for 20 years, but it illustrates how hard it is. Next time you hear about a new genetic finding, think that it's a long, long way from genetics to a drug, because drug discovery is a totally different type of research. And there's actually very, very few diseases where the gene has been found, other than childhood mutations, even in that case, where the gene has been found and it actually led to a drug, because developing drugs is so difficult. But at the same time, I will tell you that we have a special program to attack this, and we're currently funding drugs to fix the ApoE, and we're very hopeful that this is one of our main efforts right now, is to try to fix this ApoE, because it's such a powerful risk factor. Diabetes. Diabetes turns out to be a risk factor for cognitive decline and for Alzheimer's disease. And there's lots of reasons. First of all, if you have hypoglycemia, your brain is 3% of your body weight and uses 25% of the glucose that's produced in your blood. It's a high energy, it's the highest energy user in your body. It's very dependent on glucose and oxygen. And so diabetics, for example, who get too much insulin, who have hypoglycemia, when they get hypoglycemia, they go unconscious within minutes. That's how dependent your brain is on glucose. And insulin resistance, which you've probably heard about, is also really bad in the brain because it prevents your brain from being able to utilize glucose. So my point here is that there's a lot of drugs that are out there for diabetes, and we're doing something called repurposing those drugs for Alzheimer's disease. So, for example, the classic repurposing story is Viagra. Viagra was originally being developed in people for pulmonary hypertension, and there was a side effect. And the men came in and said, I got a side effect. And so Viagra was repurposed from pulmonary hypertension to erectile dysfunction. Well, that's actually really good strategy for developing drugs, because you can take drugs that are already on the market, and if they work for Alzheimer's disease, I can prescribe them the next day that paper comes out. And that's also true before the drugs get approved. So we're funding something at the Imperial College of London, something at the University of British Columbia, something at Columbia University, and a biotech out of Kalamazoo, Michigan, which was spun out of Pfizer. And all those companies and others have diabetes drugs that we're helping them to test in Alzheimer's disease. And actually, the biotech company is coming in to see us in a few weeks and tell us the results of a clinical trial that they did with our money of a very novel diabetes drug that they're repurposing for Alzheimer's disease. And I'm very excited to hear what they have to say. Now, my last story is about hypertension. Now, over 50%, almost 65% of older people have hypertension. And you know that hypertension causes heart attacks and strokes, but it also causes cognitive impairment. It causes tiny little strokes, not just the big ones where people get paralyzed. In fact, the tiny little strokes in areas of your brain where you're thinking are silent strokes. They're silent strokes. And they accumulate, they're silent strokes. And they accumulate over time. And with MRI, the MRI technology is incredible. Here you can see a normal brain under MRI, and here you see what's called the white matter disease, white matter lesions, okay? Now actually, Alzheimer described this in 1906. He called it Binswanger's disease. The man was brilliant. And he said that there was a white matter disease of the brain that causes dementia in people with hypertension, and he named it after somebody named Binswanger. So this is called Binswanger's disease. But let me just say that previously, when we did a brain scan on somebody who was having memory problems and we saw these white matter problems, it was discounted. People said it doesn't mean anything or we don't know what it means. But there's been a lot of research on these white matter lesions in the last 5 years, and I told you why they're important. That's where the connections are. You remember that slide? And so what we've found is that, as I mentioned, that people with hypertension get these white matter lesions. And these white matter lesions are associated with impaired gait, balance problems, and cognitive decline, memory loss, and they cause dementia. Now this would be a low-hanging fruit because they also cause Alzheimer's disease, and there's a lot of hypertension drugs. And so what we've seen recently is that if you treat dementia in people that are having cognitive decline, you can prevent the progression of the dementia. And in fact, if you treat people with hypertension before they even get cognitive impairment and gait impairment, you can prevent them from getting dementia. So there was one study in Europe where they were able to prevent 50% of the cases of dementia and Alzheimer's disease within 3 years by giving them an antihypertensive drug. So this is really very exciting strategy now, and that we've discovered is that some of the antihypertensives are actually neuroprotective. And so what we're doing in Canada and in the US and in Europe is we're funding drugs that are special kinds of antihypertensives that are neuroprotective. And I'm very excited about that because, again, that's a low-hanging fruit. That's something we really know. And the day that study comes out, if it's positive, I will be able to prescribe that drug. So I hope in this, just let me show you one more slide here. I'm not going to read this, but I just wanted to mention prevention. I'd be happy to answer any questions. Just sort of scan this slide really quickly. I've talked about this right here to you today, but if you look through this slide, you'll see that we know a lot about other risk factors, and we know a lot about, I think, how we can prevent Alzheimer's disease. So let me conclude by saying that we've made tremendous progress. Today, and I started in this 35 years ago, we didn't know anything, believe me. Today, we can make an early diagnosis of Alzheimer's disease specifically with that new scan. That's a huge advance. And that there's a lot of hope because there are many, many different kinds of disease-modifying drugs under development now. As Nancy mentioned, this is our space. We don't fund basic research. We just learn from basic research, and we only fund this preclinical drug discovery where innovation is, and we try to pull them through into clinical trials. I hope I've give you some examples of that. We fund internationally. Let me just close because I have clay feet. I've been a geriatrician for almost 35 years. I've taken care of thousands of people with Alzheimer's disease and their loved ones, their care, family, my own father, and I know what this human toll is. Let me tell you one story. When I first started my geriatric medicine career, I went into what was called at that time an academic teaching nursing home. Very few doctors ever went into a nursing home at that time, and even today. And I walked into this building with 300 people in it, and there were 300 people who had Alzheimer's disease. I had never seen Alzheimer's disease before in medical school, in my clinical training, and I saw all these people who were basically being warehoused in an institution. It was a fine institution, beautiful building. And I really couldn't believe what I saw, and that's how I got inspired into this field. But I was told a story. And the story was that one of the women who was in the nursing home had written a poem, and the poem was called The Butterfly and the Dragon. And she said that once I was a butterfly, but now I look like a dragon to everyone. She said, but the butterfly still lives within me if you'll only look for it. And I think at the end of the day, whether we have effective drugs or not, and we're going to have effective drugs, we're going to have to take care of these people. So let's not forget that. Thank you very much. Come to put the slide back up. Put the slide back up. Can you put... I'll be happy to take any questions. Okay, Linda.
This real close.
Okay. Can we get this?
You mentioned sleeping pills.
Sleeping pills.
Yes.
Okay.
And you said that is a very bad thing.
Right.
Explain that.
Okay. Well, sleeping pills are bad for you. Even Ambien, which is short-acting. We know Ambien causes amnesia in people the next morning. Older people have poor metabolism of drugs. It lasts longer. I mean, sleep disorders are very common. If you take sleeping pills over the course of time, they're going to accumulate, and it has an effect. I've seen many elderly people who are basically addicted to sleeping pills. So what I'm saying is that when I do an evaluation of a person who has cognitive impairment, I'm looking for all of the things that I can do to make them better. And one of my routine questions is, how's your sleep? Sleep is essential to life. And do you take sleeping pills or other medications that can affect your memory? Because there's many, many, many medications that affect the mind. There's a long list. The other thing I'll say about sleep, just as a note, is that sleep changes with aging. And two of the most common things that change with aging are something called sleep latency and sleep persistence. You know, when you had children, you put the baby down, the baby fell asleep immediately. I get a lot of people that come in, they say, I'm having so much trouble falling asleep. That's normal for aging. Sleep latency increases. I just need to reassure them, you don't need a sleeping pill. The time to falling asleep increases. And then people tend to wake up in the middle of the night. That's normal too, because of the sleep cycle is altered with aging and actually in Alzheimer's disease. So it's not bad if you're waking up in the middle of the night. It's part of normal aging. It doesn't require a sleeping pill. And so there's other strategies that I would recommend, but it is bad for the mind. Yes?
So you talked about APOE4, and my question is, is there a way to find out if that is your one's own circumstance? But secondly, so many people talk about not wanting to be diagnosed because there doesn't seem to be anything you can do, and why would you want to know? But from what you're saying, it appears that there are things.
Right.
If you could speak to that.
Okay, so I'll repeat the question. The question is, can we get the APOE test? And if you get it, why would you want to get it, basically? Because I mean, the presumption is that we don't have drugs to prevent it. Okay, so yes, I can order the test, I can write a prescription, take your blood, it goes off to a special lab, and I can get the APOE test. Most of the time, people who ask me about APOE, it's because they have family members. And if you have one family member, like a mother or a father or a grandparent, who had Alzheimer's disease, your risk goes up about 5 times. And if you have 2, your risk goes up about 10 times. And a lot of that risk is from APOE. So people want to, most of the people who want to know, they have a family risk, and they want to know if they have E4. They maybe want to know if they're going to give that E4 to one of their children. The question about why is a common question in medicine. It's called the value of knowing. There's no answer. Everybody is different. I will talk to you and I'll say, what is the value of knowing to you if you have E4? Same thing with prostate. We all go for prostate tests. We have no idea really whether they work or not. A lot of tests, the value of knowing is very individual. That's why we call it the practice of medicine. But I will say that if you got the test and found out, for example, that you were double E4, you got one from your mother and one from your father, and your risk was 20 times the average population, and you were going to get it earlier, I think it would change your lifestyle, especially if you weren't living a healthy lifestyle. And the other thing is, and this is a little bit of a sell, which I've learned from Leonard, but I think, the people that I've found who have double E4, they want to work with us. They're like very moved and very motivated to work with us, and they get their affairs in order and things like that. So I agree that I can't offer you a cure if you're ApoE4, but then I'll ask you one other thing: how many chronic diseases of old age can we cure?
Right.
0. Okay, heart disease, despite Lipitor and all of its wonders that we think about, is by far the leading cause of death. But people still get their cholesterol checked, so it's the practice of medicine.
We have a question.
Okay, sorry.
Just a quick question about memory degeneration.
Memory generation?
You mentioned how you lose the ability to recognize food and then swallow.
Yeah.
Do you eventually lose the ability to recognize hunger, or is that part of the primal brain that's not affected by the disease?
Well, it's hard to know. Obviously, it's hard to know. The question is, do you recognize hunger and some other basic facts about, or motivational, like thirst and hunger, for example. And I think you don't lose thirst and you don't lose hunger, but you obviously can't tell anyone if you're hungry or thirsty. I think the thing at the end of life is, what you're really raising at the end of life is whether we should be feeding, and providing food as comfort to older people who are basically in palliative care. They're dying. They're at the end stage of Alzheimer's disease. And again, that's a very individual type of decision.
At what point would you know that you weren't able to make decisions for yourself or your family?
Okay, a great question, a really important question. So the question is, at what point would you know that you cannot make decisions for yourself anymore? Now, this is a really common question that we get. It's a really important issue for families. Families are very often torn apart by this issue. And we think about competency. Competency is a legal term that is determined by a judge. And it has a very high bar for a judge to call a person, an 80-year-old person or a 75-year-old person, incompetent. But in medicine and in law, we have another concept called capacity. Capacity means that by some way we can determine whether or not a person has capacity to make decisions. So, for example, when I see a real estate contract and it's 20 pages long, do I have the capacity to sign that? No, I have no idea. But I trust my lawyer to tell me this is a good contract. And I have capacity to say to the lawyer, it's okay to sign that. I trust you. And I understand you've explained to me the basics about what this contract is, and I trust you. Now, people with MCI can have cognitive impairment, they can have memory problems, they can have problems in executive function, which means planning, judgment, reasoning, orientation, things like that. They're usually minor, but they almost always have capacity to make decisions. As people move into the dementia stages and they have agnosia and these other symptoms, most of the time in the mild dementia stages, they still have capacity. They still have capacity because they recognize their loved one or their lawyer. And when the lawyer says, for example, do you want to change your will? They have capacity to do that. But of course, children and others can challenge that. But there's a lot of literature on this issue of capacity, and it's a really important question that we're seeing more and more and more of. And I think part of the issue is really that the person who is questioned as far as their capacity should be evaluated, particularly because maybe we can make them better, but especially because a good doctor can help them to determine whether or not they have capacity. We have literature in the medical literature about how to measure someone's capacity and help them and their family members to determine whether they have capacity to make decisions simply by giving what we call assent, saying yes or no. They basically understand the issue.
Thank you. Excellent presentation.
Thank you.
I have a two-pronged question. I've heard that people who have Down syndrome are statistically more likely to develop Alzheimer's and die from it. So my question is, does it follow then that people who have learning disabilities or ADHD are also equally likely to develop Alzheimer's? And to follow up your point about certain drugs triggering Alzheimer's, would the ADHD class of medicines be triggers, or what other medicines would be triggers?
Right. So I think the Down syndrome example is an example where you have a mutation, right? You're born with it. It does lead to what looks like Alzheimer's disease in almost everyone, but there's two different kinds of Alzheimer's disease. There's the kind that's made by this mutation, and then there's the kind that 80-year-olds get. In other words, the disease, when the mutation drives the disease, that's really, even though at the end it looks like plaques and tangles, it's really driven by the mutation, so the treatment would be different. So Down syndrome is one thing, and Alzheimer's disease of old age is another. You know, as far as drugs, you're asking about developmental issues, taking drugs in childhood, could that be a risk factor for Alzheimer's disease? We actually know that there are many childhood risk factors. There are some childhood risk factors that predispose a person to Alzheimer's disease. So, for example, years of education is a risk factor for Alzheimer's disease. This has been shown all over the world, including a huge study in China. People who don't graduate high school versus people who graduate from, let's say, graduate school. People who graduate from graduate school have a lower risk of Alzheimer's disease. Now, you might say that's a socioeconomic thing. They have better lives. But the fact is that it's not a socioeconomic thing. What people are doing in childhood and young teenage and young adulthood is they're building the brain. They're building their brain. They're increasing their cognitive reserve. This is really important to think about, that the brain is what we call plastic. It grows and it shrinks depending on the environment, how much education, whether you remain socially engaged, or if you drop out of the world at age 70, 75. If you drop out of the world at age 75 and you live alone, your brain will shrink and you will be more at risk. But it starts in childhood. And in fact, even the ApoE story, if you're ApoE4, we know now that even when you're 5 years old, you think differently. As far as drugs and ADHD drugs, I don't think we know the answer, but I think it's an important question because so many children are being put on these drugs that are altering their brain permanently, and I would suspect they would be risk factors for Alzheimer's disease in late life. Yeah. Okay.
Thank you for another excellent presentation. I had two preventative quick questions.
Yeah.
One, especially if Alzheimer's runs in your family, at what age can you start the ApoE testing? And secondly, in terms of vitamins, that type of thing, what do you recommend?
Okay, you can get the ApoE test at any age. It's just a blood test, and it's part of your gene pool, so you can get the test at any age. As far as vitamins, it's a good question. I'm glad you asked. So I mentioned, vitamin B12. So a lot of older people get a disease called pernicious anemia. It's a very common disease, and basically it affects the stomach lining so that people can't absorb vitamin B12 anymore. There are other causes of vitamin B12 deficiency, but vitamin B deficiency is very common in older people, and if you're vitamin B12 deficient, you will have memory problems, and it is a risk factor for Alzheimer's disease, and we routinely check for vitamin B12 levels, and if you're deficient, we give you supplements. Vitamin D deficiency also can cause cognitive impairment, and I generally always check vitamin D. Again, I won't go into all the research, but vitamin D is another one. And then other dietary factors, I mentioned omega-3 fatty acids and things like that. So vitamins are quite important, actually. One more question.
Oh.
Hi. Go ahead. Sorry.
Your message is so compelling.
Thank you.
And
I'll repeat the question. Okay.
your message is so compelling.
Yeah.
But you're once a year. There are many medical centers that are doing your work, but their message does not get out the way yours is. To come in once a year
Thank you.
and to hear your fantastic report, I think is something that our community as a whole would benefit from.
Okay.
Have you ever thought of coming in and presenting this lecture?
Sorry. I'll repeat it. Well, it's a little embarrassing to repeat because it was really a comment, which I greatly appreciate. But, do you want to repeat it? Go ahead. Yeah.
Your message is so compelling. Our loss is that you are only here once a year.
Thank you.
There are many research universities within the area where your message would absolutely be essential to educating the public. Is there any way that you can come in and partner with your message and what you're doing to inform the public and to have some type of partnership? Because I don't think anyone has ever explained it as well as the Alzheimer's Drug Discovery Foundation.
Okay, well, thank you.
Once a year is not enough.
Okay. Well, thank you very much. We'll be back. Thank you very much.
Doctor.
Thank you. Are we still there? No?
I don't know why it goes off. It's on.
Can we hear me? No.
Maybe. What's going on?
Testing?
Can we hear me now? No.
Here, you want this, Leonard? You can have this.
Oh, wait.
Hello?
How's this? Okay. Next year we do it a little bit better.
No, they're not. It's not on, Leonard. Leonard.
That's it. Anyway, listen, I think we have a marching band coming. We do? Ladies and gentlemen, thank you very much. But the point here is this. There is so much we can do. Everyone says we can't do anything. You can, and we will. And with your help, not only will we find better means to prevent this and to cure it, but to get better information, and Alma, thank you for that, to get better information to make sure that everyone in this room and your families can benefit from all of this. Thank you for your patience. And I think we are going into lunch, but lunch is somewhere. Right over there. Thank you very much. God bless you all. Thank you.